Hello, everybody. My name is Joel Schwartz. I'm your trust manager. This is the first in a series of audio files that work to answer important questions to help you better understand the plan you are a participant of. We're hoping these audio files will improve our efforts to be transparent and do a better job of explaining how our plan works and why. This is the first series of files, and we hope to educate you and help make you a better user of your benefit. So what goes into a medical plan, and how do we fit in, is the question we're going to try to answer. This is an important question and important to understand how to use the plan with a little why thrown in. All plans are basically the same. They have a defined plan document that specifies all aspects of the covered benefits using industry standard definitions, claims, processes, and rules. They have the parts that make up the delivery of the plan, like a claims administrator who receives the claim from the provider, who determines accuracy, who determines if it's covered under the plan document, who determines any pre-authorization conditions under the plan document, who pays according to their rules or network contract guidelines, a pharmacy benefits manager who approves prescriptions based on the formulary they maintain, and it's adjusted quarterly. Also, who pre-authorizes specialty medications and prescriptions and confirm the prescription was written accurately and with an appropriate dosage and medical application. Lastly, and apply the plan document benefits. Other parts of a plan include accounting, independent auditors, legal services, HIPAA compliance services, and for those fully insured companies, advertising. Networks, the last, we will briefly discuss but explain more in the future, in future messages on how this is a critical part of our plan. The plans that incorporate all these parts of an insurance plan internally, like the United Healthcare's, include all those services as part of their premiums they charge. These internal departments are another revenue source to pass on in premiums. They're called fully insured plans. Self-funded plans like ours annually review and engage companies that specialize in all these services. We can negotiate and work to keep the impact to the rates part of the administrative costs at a minimum. They are called self-funded plans or partially self-funded. Other similarities in how providers are presented to those covered. Most plans have a PPO, preferred provider option. That means a list of providers are made available to covered persons, and when chosen, they are in-network. If a provider is not on the list, they are out of network. Most plans, in order to encourage the choice of network providers, make the out-of-pocket expense after the deductible lower for in-network and more for out-of-network. For example, in-networks are associated with the 80-20 or 90-10 plans, which means you pay 10 or 20% of a claim after the deductible is met. Out-of-network is common to see a 60-40 split, where you pay 40% after the deductible is met. To further discourage the out-of-network use, many plans separate each side with its own maximum costs. An example, after the deductible is met, there would be two uncoordinated maximum costs involved when using both in and out-of-network providers. If a plan does coordinate with one maximum amount before the plan pays 100%, it's usually a higher out-of-pocket expense and accompanies a higher premium. When traditional networks began to be widely used, plans would either create their own network or rent a network from a company that has one. This ends the first audio file. The next one will be how traditional networks don't help you or the plan, and explain networks a little bit better.